All right. Simmer down now. Simmer down now. All right. Well.
Team one?
Are we team one?
Yeah.
We are now.
1, 2, 3, 4.
All right, team one. Oh, new rules today. All right, no one's actually close to me, so I'll just. New rules today. It's raise your hand if you know the answer, and if you get it wrong, you get points off this time. So we played that, you just shout out, but then I couldn't understand anyone last time. So you got to raise your hand, and if you get it wrong, you get points off, okay? All right, Samir, start us off, brother. Pick one.
Cool. Derm 100.
Derm 100. Patient presents with this extremely pruritic rash after a camping trip. Is the correct treatment. The rash is on all over its arms, on his legs, and also on the patient's stomach, all over the body. Eric.
Oral steroids.
Woo! There we go. You are correct.
Is there anything on the line that we go negative?
So a little bit of teaching. So when we think about contact dermatitis, what happens? You got a little hapten here. This hapten taken up by those keratinocytes right here, and that hapten kind of binds with them, and then it's antigenic. So you get this T cell infiltration here. These T cells, mostly CD8 T cells. And these CD8 T cells then attack these keratinocytes. These keratinocytes then become apoptotic. And when you have this apoptosis here, you get fluid extravasation, apoptosis, and that's why you see vesicles. So you see the vesicles on exam, on rash right here, and you also see that erythematous base from that T cell infiltration and destruction, keratinocytes, and then secondary vesicles. So when you're going through how to treat this, it kind of depends. If it's mild to moderate, you want to do, you just want to do just topical steroids. You want to do high dose unless it's on the face. But if it's multiple body parts, so if it's all over, you really don't want to put steroids on every single part of that patient's body. So in those cases, you'll do oral prednisone. You actually do a pretty prolonged taper, times 2 to 3 weeks. All right, perfect. So we got that one right. What do y'all want to do next?
We'll do STIs for 100.
All right, STIs for 100. Empiric treatment for anyone with suspected chlamydia, gonorrhea infections. Travis. Ceftriaxone and Zithro. Got it right. So
I'm so afraid now we can go negative, actually.
that's the point.
My confidence is slashed.
So anytime you got urethritis, anytime you got cervicitis, especially in a younger sexually active patient, or really any patient at all if you're suspicious of an STI, you want to give them ceftriaxone. You only need 1 dose, an IM dose, and then you also do 1 gram of azithromycin. You can do second line for doxycycline for seven days instead of the azithromycin, but azithromycin's first line. If they have epididymitis, you might end up going with doxycycline. That's the only time that may jump in front of azithromycin. So remember, ceftriaxone is for the gonorrhea, azithromycin is for the chlamydia.
Is this true? Dr. Ackerman told me last week that now doxy is first line.
Yes. Yeah.
Okay.
Invalid question, no point.
Invalid question, but still points. Because I'm going off McSep 18, so this is all from McSep 18.
Yeah.
But it changed. I mean, stuff changes, especially treatment guidelines.
There's more resistance to Zithro.
I guess that makes sense. So I'm a little behind the books. I apologize. But what will happen, they'll probably throw that question out on your board exam then. So remember as well, chlamydia is really the biggest one that you're looking at. Chlamydia is a really common cause for infertility in females and an acquired cause as well. Can be asymptomatic for a long time, and even when it's asymptomatic, it still cause fallopian tube damage. So just always be on the lookout for chlamydia. Anytime you have a sexually active person, they need testing for chlamydia, gonorrhea every year. All right, so just remember that. And if the patient has PID, so, you know, and really this is going to be diagnosed with like cervical motion tenderness on exam. They may have abdominal pain, fevers. If they're sick enough to be inpatient, they're going to do IV cefotetan, probably saying that wrong, and IV doxycycline. Outpatient, it's going to be 1 dose of ceftriaxone IM, doxy, and metronidazole for 14 days. So remember, really what PID is that these patients get a chlamydial infection or a gonorrhea infection. That kind of basically leads to incompetent cervix, and they have actually ascending polymicrobial infection in their uterus, and that's why you have to kind of treat with these more broad spectrum antibiotics. All right, back to the board. What do we got? So that was STI 100. What do we got? What do we got?
All right, Opry 100.
Opry 100. So this is generally like just stuff, that random stuff that the Chiefs watched on Netflix or some other channel.
Oh, it's not medical?
No, no. All right, who invented the black hole theory?
Stephen
Yeah, I'll give it, but you gotta raise your hand. And Sony watched a pretty decent show on black holes. So.
Edge of, what is it? Edge of what we know.
Edge of all we know.
All we know. So good. Everyone should watch it.
Check it out. All right, Potpourri 100 is down. What do we got next? Potpourri for 500. Birth name of the LA serial killer, colloquially known as the Night Stalker. You got to raise your hand. We got some Hispanic guy that doesn't count. Anyone's got the grapes? Yeah, that's fair. I don't think I would have. All right, it is Richard Ramirez. You were right, but and that was the Night Stalker. All right, no points for anyone. What do we want? All right, let's just get these out of the way. 2021 Oscar winner for Best Picture. Raise your hand. Oh no. Minari. I don't think you guys can go again. Yeah. Does anyone else have a guess? It's not Minari. All right, 1, 2, 3. All right. Nomadland. Yeah, I didn't know that. So, all right. What was that? 200 Potpourri. All right. What do we got? What do we got? You guys still?
300.
For Potpourri?
We're gonna do it.
Potpourri is so, you know, how many? Oh, this one's good. How many tentacles does an octopus technically have?
Oh,
It's a trick. You think? Come on. You think I'm gonna get you with octo?
0.
0. Yes, he's right. And why 0? Why 0? Why 0?
We got bonus points on it.
All right. What if they had like 2 tentacles? No, they're technically called arms. Yeah, octopus have arms.
You can't call them tentacles.
It's only squid and cuttlefish and nautilus.
Cuttlefish.
Yeah. So.
Like octopus teacher.
Octopus teacher. All right, what do we got? You guys. All right, what's the PA hospital highlighted in the show Mayor of Easton? Ooh, Riddle Hospital. That's what it looks like. All right, so we got the Potpourris out of the way. What do we want to do next? Anybody? Team, what team is that? Great. STI 300 STI. Patient presents with fevers, arthralgias, Psoriasis, Travis. Ooh, no. What is the diagnosis? We got one here. Disseminated gonococcus. Good, very, very good thought. The only thing that differentiates that is, see that little pustule right there? Yeah, so when you're thinking about disseminated gonococcal, it's not really clear whether this pustular rash is actually infection or if it's kind of a hypersensitivity immunological reaction. But the things that you think about when you're thinking about disseminated gonococcal is that these patients are going to have dermatitis, so that pustular rash. Sometimes they put like gun gray with a gun gray base. That's what I've heard before. They may have tenosynovitis as well. So I think I saw a patient with this that had like Achilles tenosynovitis. I think tenosynovitis in their hand as well. And then the other one that you can get with disseminated gonococcal, you can get this dermatitis tenosynovitis syndrome. The other one you can also get is monoarthritis as well. And you really have to treat that pretty similar to actual bacteria monoarthritis. So it's going to be IV antibiotics. And patients with monoarthritis from gonorrhea, they're going to need joint drainage as well. So treat it just like a regular bacterial infection, but you might just kind of go with ceftriaxone. All right.
All right, guys, let's pay attention.
Yeah, you guys, shush. All right, so disseminated treatment is going to be ceftriaxone for 7 to 14 days, as well as azithromycin times 1. So anytime you're treating gonorrhea, remember you always got to treat the patient for chlamydia. I guess maybe it's doxycycline now, so that's a new one. All right, so 300 for STIs. What do y'all want next?
Whatever you want. Let's do STIs for 200.
All right, 200 STIs. This patient had a JHAP. They were treated empirically for cervicitis with ceftriaxone and azithro. Didn't improve. Her urine chlamydia. Who was first? Good. Yeah, we got it. So this one, and can you tell me what causes it? Yeah, so this is Trichomonas. I really put this one in. Hey, guys, stop. So I really put this one in basically because you always need to think of Trichomonas anytime someone has cervicitis or urethritis as well. So anytime you're empirically going to treat with ceftriaxone and azithromycin, but send off that urine gnat for gonorrhea, chlamydia, and also Trichomonas. So send it for all three anytime you have someone with any of these diagnoses. And that's correct. The treatment is going to be metronidazole, 2 grams times 1. If they're refractory, you're going to do BID for 7 days. The typical stuff you learn in medical school, like the strawberry cervix, the green mellitus discharge, doesn't usually occur. It's only in like less than a quarter of cases. So it's just going to present looking like chlamydia or gonorrhea. So just remember that. All right. So that was STIs 200. We want next. All right, STIs 400. All right, your patient presents with this painless ulcer as well as this enlarged inguinal lymph node. Chlamydia gnat is positive, syphilis is negative. What is the treatment?
It's LPV.
Yes, and what is the treatment?
What is the treatment? Sorry.
Yeah. I'm giving 5, 4. Doxy, good. You guys got it. All right. So this one's kind of crazy. I mean, I remember learning about LGV, but I didn't really know how to treatment. So, it's going to present with that kind of painless ulcer. The thing that's going to clue you in is that tendon inguinal lymphadenopathy. In the U.S., the most common presentation of this is actually prostatitis, or sorry, not prostatitis, it's actually proctitis. And think about it in a patient who's MSM as well. That's kind of the category of people who get it most often. The diagnosis is kind of crazy. So the chlamydia gnat is actually going to turn positive because the chlamydia gnat doesn't tell you what serovar it is. So if you have a positive chlamydia and you have a patient who is clinically presenting like LGV, you treat it as such. And the way that you treat it is actually you do extended doxycycline treatment. So, usual it would be 7 days, but you actually extend it all the way out and do it for 21 days. All right, that is that one. What do we got? What do we got? Room for a hundo. I think this one's kind of hard. Best medication to treat multi-articular gout flare in a patient with a history of end-stage renal disease and advanced cirrhosis. Tim. Ooh, yep, you're right. Oh, what route?
It doesn't have to be route.
No, I got to be a little specific. I'll give you joint or oral. Are you gonna do a joint injection or oral?
I would do oral.
Good. All right, you got it. It wasn't really 100 questions, to be honest. It's kind of hard. So when you're thinking of gout and you're thinking of how to treat this, it becomes very difficult because of a lot of the things that set you up for gout makes it like a pretty much a contraindication for a lot of the treatments for gout. So when you're thinking of it, you really want to look at what the patient history is, what their past medical history is, what kind of things are going on with the patient before you think about treatment. So first line is going to be oral NSAIDs or oral steroids, or intra-articular steroids. So the reason why we couldn't do intra-articular steroids here is that if you have greater than 2 suspected joints, you can't do it. So this patient had 3 joints, so intra-articular steroids was out. NSAIDs, why couldn't we do NSAIDs? A couple of reasons. The patient has end-stage renal and they're still kind of making urine, so they might have a little bit of renal function left. And they also have advanced cirrhosis, so NSAIDs were out as well. Colchicine is kind of an alternative, so it's not what you originally would go for an acute flare. And the other reasons why you couldn't really do this in this patient is that they have end-stage renal disease and they have advanced cirrhosis. So both of those together is a contraindication. You can still give colchicine to patients with renal disease. You just have to reduce it. And always watch out for those cytochrome P450 inhibitors if they're on one of those, because it might be a contraindication that you can't do colchicine. Last one, anyone who you're going to need colchicine and they're South Asian, make sure you do an HLA 5801 test as well, because they can actually develop really severe reactions to colchicine. So that's like a new one on mixed app. They have to test those patients before you give it. All right, cool. That is gout for 100. We got. What do we want? What do we want? Keep that train going. Let's do it. Room 2. Name one indication, looking at you, Danny, for long-term uricosuric lowering therapy in patients with an acute gout attack. So, okay.
More than one flare.
Per, and what time period?
In 3 months.
No.
I think that would be an appropriate time to give.
Okay, I guess technically if it's within 3 months, you're right.
Yeah, it's a subset.
I'm not gonna take any points away. I'm not gonna take any points. Neutral. Neutral. All right, why do you want to start the allopurinol? What makes you think about doing the allopurinol? Anybody else? I scare everyone now that they were close. They just didn't have the time period correct. Are you raising it? All right, Grotsky. Yes, there we go. Tophi. All right. So when you're thinking that, I mean, gout is, when you get to the treatment of gout, it can be pretty complicated. So when do you want to start actually uricosuric lowering therapy for gout? So it's greater than 2 flares per year. So if they have greater than 2 flares, or greater than equal to 2 flares a year, sorry. If they are high risk, and this is the one I think you get most people on, especially so many people with gout have CKD. So if they have anything worse than CKD3, you actually want to start those patients on uricosuric lowering therapy. And lastly, what you guys got it on, any complications. So complications are going to be tophi, if they have an x-ray with joint erosions, if they have urolithiasis. You're going to start uricosuric lowering therapy. So you're going to start something like that. So you will also not only start urate lowering therapy, you want to start inflammatory prophylaxis. So remember, when you start urate lowering therapy, you actually put them in increased risk for a flare. So you're going to start actually allopurinol, and you're going to start low-dose colchicine pretty much at the same time. Some people say you got to wait 2 weeks for allopurinol after an acute flare because you don't want to worsen the flare. There's some studies now that shows that you can probably start them at the same time. I would still wait 2 weeks until like the guidelines change. So, and anyone you're going to start this long-term therapy on, you want to start allopurinol, and you also want to start low-dose colchicine. And the question is always like, when do you stop So you really want to get their goal urate less than 6, but you will never stop that urate lowering therapy. So they'll stay on that allopurinol for life. The inflammatory prophylaxis, once you get that urate lower than 6 for about 3 to 6 months, you think that you're kind of safe. You think that they're not going to have another flare. You have their urate under control, and then you can DC the colchicine. Okay, so that's kind of long-term management of gout, and I see gout all the time, and JHAP and things like that. So knowing this can be very, very helpful. And they almost always get it for the CKD3, I feel like. All right, that was room for 2. Roski? Room for 3. All right, 40-year-old male presents with joint pain. His knees, his x-ray is shown. Arthrocentesis shows positive birefringent rhomboid crystals. Name one disease you need to screen for that puts you at risk for this disease. Ooh, all right, great job. Hemochromatosis, exactly. So this is pseudo gout. So pseudo gout is from calcium pyrophosphate crystals. And theirs is like the 5 H's. Some people put the 4 H's, some people put the 5 H's. But these are things that will set you up for pseudo gout. Another thing that clues you in here that it was pseudo gout is here's an x-ray of that chondrocalcinosis, that calcium deposition in the cartilage. Here is a picture of the positive birefringent crystals. For the 5 H's are hyperparathyroidism, hemochromatosis, hypomagnesium, hypophosphatemia, and hypothyroidism. So anyone that's young and comes in with pseudo gout, you have to really work up for all of these, and you want to send off a PTH, iron, like all the iron labs, mag, phos, and plus minus like the TSH. So for any of those patients that's young coming in with pseudo gout, usually pseudo gout's much more likely to be a disease of older patients. You really want to send off and kind of work those patients up. So great job. So that was room for 3. All right. What do you want? Room for 4. Treatment of ankylosing spondylitis refractory to NSAIDs. So you do the NSAIDs, still bad. What do you want to do next?
We're guessing. Methotrexate.
No.
That is definitely one.
It is one of the treatments, but it's not the next go-to actually for ankylosing spondylitis. No. TNF alpha. So we got some minuses, we got some pluses. So it is TNF alpha. So you guys had it, but there's a different seronegative spondylarthropy. So treatment for seronegative spondylarthropy is all mild cases. You start with NSAIDs. If you have refractory or moderate disease for ankylosing spondylitis, your next line is actually going to be a TNF alpha agent. It's kind of weird because it's something that's backwards. You always think about like steroids for immune disease, like autoimmune disease, but really your first go-to with ankylosing spondylitis that's really not doing well with NSAIDs is actually going to be a TNF alpha agent. For reactive arthritis, it's kind of like Mixed will test you on like intra-articular steroids or oral steroids, but there's other DMARDs that you can give as well, like sulfasalazine and methotrexate. So that they might not test you on that, but if they do, it'll likely be like joint injections with steroids if they're pretty symptomatic. And then with psoriatic arthritis, so remember, anyone with psoriasis or psoriatic arthritis that you want to do a systemic therapy, your first line go-to is going to be methotrexate. All right, and then if any of these are refractory, that's when you think about TNF alphas. Newer agents for psoriatic arthritis is ustekinumab and secukinumab, which are IL-23 and IL-17 inhibitors. So that might be something you go to as well. But this is kind of just the treatment for seronegative spondylarthropathies. All right, why do I not have? Can't return to the board. 1 second. All right. So that was room 400. What do we want? 500. All right. Oh, this one's really tough. 80-year-old female presents with insidious shoulder pain, limited range of motion, and infusion. X-ray shown arthrocentesis was blood thin, but you didn't find any uric acid or calcium pyrophosphate resistance. Name the syndrome or name the type of crystal deposition that causes it. I'm honestly not expecting anyone, unless you did the specific mix-up question, I'm not expecting anyone to get this. In the shoulder, you can see, doesn't really look that good. It's got all this hyperlucency deposition in the joint. Milwaukee Shoulder, anybody? Anyone heard of this? Have you seen this? Have you heard about this? Anyone? No. All right. The Milwaukee Shoulder. So this was a mix-up question. That's the only reason why I put it on here, because it's very, very difficult. And this is secondary to deposition of hydroxyapatite crystals. People who are set up for this are like old age and females. The very typical presentation is going to be an older female who's coming in with a swollen joint, but then you do an arthrocentesis and it's non-inflamed, but it might be a little bit blood tinged. And then all the crystal work is going to be negative, but you're going to see basically calcium deposition in their joint right here. There is, like, you can do microscopy for this to look at the crystals, but it's really not symptom specific. So diagnosis is really going to be clinically, and then treatment is basically typical stuff, physical therapy, NSAIDs, but then you actually want to aspirate that joint and put steroids into it. So kind of a new one, but this was a mix-up question, and it was pretty hard, that's why I put it on here. So Milwaukee Shoulder. So no one got that. Where do y'all want to do? I think it's still y'all. What do you want to do?
Let's do derm for 200.
All right, derm for 2. Patient presents with the rash shown. It covers less than 10% of the body. What is the treatment? Patient be specific.
What? How is it more severe than? Well,
Just give me like
less
dose.
than 10%. I mean, your options are UVA therapy or topical steroid. Yeah.
But is it, how, like, what kind of dose? Topical steroids, low dose? Is it...
I'm not in that one.
I just treated a patient with, Jay Happ the other day.
So what dose of topical steroids?
Just a general range.
High dose topical.
There we go. I love that. I love that. So high dose topical steroids. And just, you don't want to put hydrocortisone on this. It's low dose. It's not going to do anything. So what is it? This is psoriasis. You can see that kind of silvery scales. You can see that erythema. So what's the deal with psoriasis? How does it happen? So here's normal skin right here. So basically there's some sort of antigen thing going on here, taken up by dendritic cells. They then actually activate T cells. And the way that they activate this is IL-23. And then those T cells basically come into the epidermis here. So you can see this nasty T cell inflammatory infiltrate here. Those T cells then secrete IL-17, interleukin 17, as well as TNF alpha, and that causes a couple things. So the big thing that it causes is that your epidermal layer gets very thick, and you also get a big thickening of your stratum corneum as well. So the keratosis on top gets thick, and also your entire epidermal layer gets thick as well. And that reaction is kind of what makes it look like it looks on exam. So when you see it on exam, you're going to have that erythematous base, which is that T cells causing that inflammatory reaction. And then it's going to be thick and very scaly, which is like that hyperkeratosis, that thickened stratum corneum, all from this immune reaction that's causing really activation and high turnover and thickening of your keratinocytes. So treatment-wise, if you're going to have limited disease, this is called less than 10% of your body surface area, you had a lot of the right therapy. So high potency steroids, unless it's on the face or on the groin. You can do topical vitamin D. You actually can combine it as well. So you can do both at once. And you can do phototherapy as well. Once these patients have greater than 10% body surface area, if it's in the head, the scalp, they have psoriatic arthritis, at that point you have to do systemic therapy. We kind of went over this a little bit already. Methotrexate, retinoid, cyclosporine, or some of the biologics. And that was 2 that I was kind of going over in the pathophysiology. These are new biologics that block IL-17 and IL-23, which really causes T cell activation and immune response with that keratinocyte proliferation. So blocking them is actually proven to be very effective, but super expensive. And those ones are secukinumab and like ustekinumab. So these are kind of new biologics that we can use. You can also use TNF alphas. So cool. Let's get back to the board, and that was Derm for 2. What do y'all want next? All right, Nephro for 4. Oh, these, you guys aren't going to enjoy this one. Your patient with Sjögren's syndrome presents with a non-anti-GAP metabolic acidosis and hypokalemia. Your non-anti-GAP is positive, indicating renal bicarb loss. Chistitis syndrome, creatinine is mildly elevated. Her urine pH is pretty high. It's greater than 5.3. What is the most likely cause of this non-anti-GAP metabolic acidosis? Something that you see on the, yes.
Type 4 or 2 renal acidosis.
Whoa, not type 4.
Type 2.
It is. It's not type 2. There's only one left. Type 1. For the life of me, I do not know why they named them the way that they named them. It was so stupid. You would have think proximal would be type 1, distal would be type 2 maybe, but I don't know. It's all over the place. It's really ridiculous. So this is the biggest etiology you're really going to get. Potential etiologies. I'm not going to go through all of them. There's only a couple ones that they're really going to test on the boards. For distal RTA, the biggest one that they love and the most common cause of a distal RTA is Sjögren's syndrome. And really, what is a distal RTA? So remember, in your collecting duct, you have resorption of sodium, and that sodium is then exchanged for hydrogen as well as K. So what happens with the distal RTA, it's actually a problem with the hydrogen channel. So since you're having a problem with the hydrogen channel, what happens is that hydrogen will then go back into your body, causing a metabolic acidosis. That's a non-anti-GAP metabolic acidosis. And because you're not exchanging that, you're going to get a really, really high secretion of K into your nephron, and that K is going to be secreted. So that's kind of why you get the acidosis. That's why you get the hypokalemia. And then for diagnosis of this, you need to do a urine anion gap as well. The one thing here that the urine pH is greater than 5.3, that might help you a little bit. And the reason why is that these patients, they really can't acidify their urine at the very end of the process in the collecting duct. And because they're not secreting H, they're going to have basically a really high pH urine that's higher in bicarb and not acidic. All right, cool. And then treatment, it's just going to be oral bicarb. So to treat these patients, you're going to do oral bicarb. You may give K citrate just because that'll give them a little potassium too. All right, back to the board. That was the 300? 4? All right. Yeah, everyone always forgets about the RTAs, but you might get on the board, so if you're going to go over them.
300.
All right, 300 for nephro. I'm going to exit out before I do it. Diabetic patient presents with a non-anti-GAP metabolic acidosis, mild hyperkalemia. She's only on insulin. The urine anti-GAP is positive, indicating renal bicarb loss. What is the most likely cause of this non-anti-GAP metabolic acidosis? All right.
Type 2 renal tubular
acidosis. Who got it next?
It was
Grad? All right, yeah, type 4. Oh, man. All right, so thinking about type 4, we kind of already went over what the collecting duct does, right? It reabsorbs sodium, it secretes potassium, and it also secretes hydrogen. Does anyone know what hormone kind of regulates all this? Yeah, aldosterone, right? So this is all under the regulation of aldosterone. So the different causes are basically different things that are going to hit aldosterone at basically every part of the renin-aldosterone axis. So some of them can decrease the renin, and the biggest one that you're going to get here is diabetic hyperreninism. It's like the only RTA you've ever seen. Once you start looking for it, you probably may see it a decent amount. Other ones, not as common, HIV, NSAIDs. The next ones are things that decrease aldo. So a big one here is going to be adrenal insufficiency, but also think about ACEs, think about ARBs too. They can also do it, spironolactone. And then lastly are things that actually cause aldo resistance. And the big one here is going to be meds. So like tacrolimus, cyclosporine, they're going to cause aldo resistance. They can actually cause this. So type 4 RTA, and what the type 4 RTA, it actually kind of does all of this. So they may not absorb sodium, and then they don't secrete K, they don't secrete H. This goes back to their serum. They get a little bit hyperkalemic, and they can also get a little bit acidic. Treatment is kind of difficult for these patients. If they're adrenally insufficient, you're going to treat them as such, fludrocortisone, hydrocortisone, things like that. But a lot of these patients, like diabetic hyperreninism, you're not going to want to give that patient fludrocortisone, right? They're probably already hypertensive. They probably already have renal disease. So what you'll usually do is like put them on a diuretic to get that K down. And that may also cause a little contraction alkalosis too. That can kind of treat it. So that's that. All right, that was nephro. I already did it. So what do we want next? Who's up? Yeah. All right, nephro for the 2. Other than an ANCA and an ANA, name another serum test you would order in someone you're suspicious for glomerulonephritis. Yeah, serum test. I won't take points off of that. But we can go to someone else. Yeah. Yeah, I think that's. I'll go with that. Yeah. Yeah. All right. So. But what's the different causes of glomerulonephritis? So I think the biggest one is ANCA. So what ANCA actually is basically antibodies directed against neutrophils. So these antibodies bind to these neutrophils. Neutrophils extravagate and they cause damage, not only in the glomerulus, but in the rest of the body. So more likely to be a systemic disorder. That damage then causes RBCs, especially dysmorphic RBCs, maybe plus minus casts. As well as protein into your nephron. So it's going to be a major clue, RBCs in the urine as well as protein in the urine. So that's your ANCAs. The next one is anti-glomerular basement membrane. So these are antibodies that are perfectly directed against your basement membrane. They're going to deposit there and once again cause that damage to your filtration system and protein and RBC loss. Lastly is actually going to be type 3 hypersensitivity reaction. So these are some sort of autoimmune or infectious cause, so some sort of antigen. And then what happens is that you have antibodies that will bind to this antigen, right? So these antibodies bind to antigen, and then because the renal glomerulus is a very high filtration system with high pressure, they get deposited in the wall, and that causes secondary release of complement, neutrophilic extravasation there, and once again, damage to the glomerulus and loss. So usually you'll see this. This is the one that you'll see in the orange book that kind of goes over the causes of glomerulonephritis. You have ANCAs, which we went over, anti-GBM disease, which we went over. And then you have these kind of type 3 hypersensitivity reactions, which the thing that's going to clue you in is those decrease in C3 levels, right? So that complement deposition from those antibody antigen complexes in the kidneys are going to decrease your complements because they're going to bind. So causes that can do this, a major one is going to be infectious. So you might want to think about sending off an ASLO for strep. It's kind of crazy because we learned that in medical school, but the bigger cause now is actually patients with endocarditis, secondary to staph, just because of the opioid epidemic. So that's actually more common than that. Cryoglobulinemia, we want to set off like a hepatitis C. Autoimmune, obviously, with lupus, and then I won't go into the MPGNs. The ones that won't have that much complement are going to be your IgA. So glomerulonephritis, so hemolux, purpura, and IgA nephropathy. It's more indolent, and IgA doesn't usually bind complement, so the complement levels that may actually be normal, and that might help you clue you in. So going back to these, when you think about the pathophysiology, remember that neutrophils are antibodies to ANCAs are antibodies to neutrophils, anti-GBM is antibodies to the GBM, and then the type 3 hypersensitivity reactions are kind of deposition of these antibody immune complexes. Really makes you understand why they stain the way they do. So you only have antibodies and neutrophils. So with your ANCAs, when you do immunofluorescence staining for antibodies, there's not going to be a ton of antibodies within that glomerulus. It's going to be called palsy immune glomerulonephritis. When you think about anti-GBM, it's perfectly located and localized to the patient's like basement membrane. So it's going to be very linear, and it's going to perfectly outline the glomerulus. And then when you think about type 3 hypersensitivity reactions, these are like basically antibody antigen deposition throughout the entire kidney. And that's why it's going to show up as a very granular immunofluorescence, because it's going to have those antibodies that you're staining for like everywhere. So that kind of tells you a little bit about what could be causing it based on your renal biopsy. All right, cool. That was Nephro 2. What do we got? Who got that?
Let's do
Derm for 3. Treatment of one medicine, treatment of mild comedonal acne. Is it okay? Well, is it which way though?
Oh, topical.
Yes. Yeah, you got it. All right. So you'll see this in JHAP. Acne treatment comes up a lot. Like we do need to know it because I mean we get people in JHAP GMO all the time that have acne. So you kind of put into 2 categories: mild versus moderate and severe. And then in mild disease, you look at comedomal versus inflammatory papulopustular. So when you look at comedomal, this means that they're not going to have a lot of inflammation around that acne. They may just have some white heads, or they may have some black heads. And the treatment is really going to be topical retinoids. It normalizes the keratinocytes. It makes them mature a little bit more efficiently. And it can actually really work well on the comedomal acne. If they have that inflammatory papulopustular phenotype, you're going to do topical retinoid, and then you're also going to add on benzoyl peroxide. I think that, what was that derm thing? There's always Neutrogena. No, the derm thing that they always had commercials for. Remember that? Like back in the price line. Pro, yeah. This is pro. I'm pretty sure this is Proactive. I think Proactive is a topical retinoid and benzoyl peroxide. If that patient still has it, you're going to add a topical antibiotic. So if they're refractory to Proactive, you're going to do a topical Clinda and Dapsone. A little bit different if they're moderate severe. If they have that nodular scarring acne, you want to be really, really aggressive, and you'll start those patients on oral isoretinoin monotherapy. Always check a pregnancy test, and then they got to sign some forms to be on this because it's super, super, super teratogenic. If they're really bad inflammatory, they're not nodular, not scarring, you might be able to get with a little bit of oral doxy and topical. And then in females, you can consider adding OCPs and spironolactone as well. So those are kind of like typical add-ons. But just remember, if it's that nodular, scarring, terrible acne, you're going to go straight to oral isoretinoin because they can have scars from the rest of their lives from acne from that. So you want to be super aggressive. All right. That was 3, right? Maybe. All right. What do we got next? What do we think? All right. This is not acne, but it looks kind of similar. 50-year-old presents with this rash shown, worse with heat and stress, involves a nasolabial film. Yes, this is rosacea. Well, what? All right. So when you think about rosacea, you got to think about, there's a couple of different types. So there is erythrotelangiectatic rosacea, which is basically a bunch of telangiectasias without really any inflammation. There is papulopustular rosacea. This is the one that you probably see most commonly. And rosacea is a little bit different than acne. So acne is with your exocrine glands. Rosacea is actually with your pilosebaceous, like your hair follicles, your pilosebaceous unit. So they actually affects a different part of the skins. And the way that you tell the difference between rosacea and acne is that rosacea will not have any comedones. They won't have any whiteheads. They won't have any blackheads. So that's kind of how you tell the difference. But they look very similar. And then you can also have Phthisis rosacea as well, which gives you that classic rhinophyma. Lastly, I won't go into it, but ocular rosacea too. It's just a cause of red eye. Might clue you in with a little bit of, you kind of see the patient's eyelid. There's a little bit of telangiectasias there. That might clue you in that it's ocular rosacea. So the things that are on the differential of rosacea is going to be seborrheic dermatitis. This is kind of an inflammatory reaction to Malassezia furfur, so like an actual fungus on the skin. It's going to be a little different. So it's greasy. It's going to be greasy looking, kind of scaly. I mean, this is basically just whatchamacallit on your face. This is basically just dandruff on your face. And treatment's going to be different. It's going to be topical antifungals like topical ketoconazole. So looks a little bit different where it actually preferentially affects the nasolabial folds or any place that has a lot of oil, because that's where that Malassezia furfur is going to grow. And the other one that's on the differential here is also going to be lupus. You're going to tell the difference is that lupus is photosensitive reaction. So it's really going to spare those nasolabial folds, which is a little bit more protected from the sun. So these are the commonly the things that are in a differential with rosacea. I'm not going to go over the treatment of rosacea right now because I don't think we have time. So that was derm for 4. What do you all want next? Yeah. These 3. STIs for 5. Patient, oh, that's good. Patient presents with recurrent aseptic meningitis. HSV2 was positive on the biofire. What is the name of this syndrome? It's like a French name. Starts with an M. No. Yeah, I think this one's a little too hard. And super rare, not that rare actually, but you know, this is going to be called Mulleray's meningitis. So secondary to, never heard of it. You knew it? Oh.
No, I forgot where it was.
It was like something you like may have heard of once in med school. Big things for, I wasn't going to give you like, oh, how do you treat HSV? But remember HSV, you know, very painful ulcers, genital ulcers. They may actually have systemic symptoms. They may actually have lymphadenopathy as well. You're going to diagnose this with a NAT or PCR, but you need to do it from an unroofed ulcer base. So it has to be unroofed. And if you have to pop it, you got to pop it. So treatment for is primary treatment is usually going to go valacyclovir or acyclovir. The thing that you might get tested on is like, when do you give prophylaxis? So like, when do you put someone on HSV2 prophylaxis for their, it's a little bit different than 1, remember? HSV2 prophylaxis for their entire life. And you're really gonna do this either if they have frequent recurrences, which they say is like every 2 months, greater than 6 a year, or if they have an uninfected partner who is seronegative for it, and you don't want them to give it to your partner, these patients may be on prophylaxis for life. So that's kind of why you might put them in prophylaxis. And then you also might even think about putting them on HSV prophylaxis if they have Mulleray's meningitis, which is actually recurrent meningitis. So remember, think about HSV1 is encephalitis. HSV2 can cause recurrent meningitis. And it's going to be an aseptic meningitis, obviously, since it's viral. All right. So no one got that one. What do we got next? Anyone? Who did that? Who got the one before that? What do you guys want? Derm, 500. All right. Your 65-year-old patient presents with just general pruritis in the absence of any primary skin lesions. Kind of clues you in is that he's itching everywhere, so he's causing these excoriations, but he can't reach his back, so his back doesn't have any excoriations on it. So these are all secondary skin lesions. Name one test other than a Chem7 and CBC that is part of the initial workup. Bilirubin? Yeah, okay, LFTs. So this is kind of an interesting one, and it's kind of more of an aggressive workup than I would think for just someone who's itching a lot. But, you know, underlying itching without any primary skin lesions can be a sign of a pretty severe systemic disorder. So think of your infectious causes. Everyone needs to get an HIV. And actually more for the neoplastic causes, but everyone actually needs a chest x-ray. And the reason why is lymphoma can cause generalized itching in the absence of skin lesions, and Hodgkin's lymphoma you may catch on a chest x-ray. So everyone with generalized pruritis without skin lesions needs a chest x-ray. Everyone should obviously get age-related cancer screening for any of the other neoplastic causes like the solid cancers, CBC with diff as well for leukemia. Always check their med list. Common ones are like opioids, sulfas, as well as some diuretics. Everyone needs a TSH with reflex. Everyone needs to be worked up for diabetes with an A1C. And lastly, for metabolic causes, everyone needs an LFT and a urine pregnancy test. So you probably can't remember all this. I can't either, but just remember, if you find someone with generalized pruritis without any skin lesions, just go to UpToDate and just check the labs that you should check, the labs and imaging that you should check, because it can be a sign of a systemic disorder. All right. Sonia, where are you going? Okay. All right. So we only got nephro for 5. Well, we got nephro for 1. What urine test is used to differentiate renal versus GI losses in patients with a non-antigen metabolic acidosis? I think you got it. Yeah, so I kind of went over this like 8 times already because I thought you guys were going to go 100 to 500, but then you ended up working backwards. But yes, it is a urine anion gap. So this confused me a lot. Like, what is a urine anion gap, and why does this tell you the difference between GI losses versus renal losses? So in GI losses, kind of what happens is you have that loss of bicarb, so loss of bicarb, as well as loss of chloride, but your kidneys are still working. So what happens in patients that have the GI losses is that systemic metabolic acidosis that is caused from diarrhea and the loss of bicarb is taken up by this sensor in your proximal tubular cells, and that sensor goes and secretes NH3. The NH3 travels all the way down your glomerulus, combines with the hydrogen ions, so that kind of acts as a buffer, and then turns to NH4+. And that NH4+ then binds to chloride, and that NH4+ and chloride combo is then secreted. So why does that do to your... So what does that do to your urine anion gap? So urine anion gap formula is Na, sodium, plus potassium minus chloride. So in someone who is appropriately having an appropriate renal response and their kidneys are working, they're going to have an extreme ton and loss of chloride. You can't measure ammonium, so you're going to measure chloride. So you have a ton of chloride in their urine. That means their kidneys are working because they're responding appropriately to metabolic acidosis by secreting this NH3 buffer that combines with NH4 that combines with chloride. So if they're negative, equals normal kidneys. And then when you think about an RTA, the whole problem with an RTA is that they cannot secrete H in their urine. They can't secrete H. They don't turn this NH3 to NH4. So they don't secrete any chloride. So if they're going to have a positive urine anion gap, so that means basically that their kidneys are bad. So positive equals, I don't know, 4 kidneys. So it's kind of complicated, but that's kind of how the urine anion gap works. So remember, if it's negative, they're having an appropriate response. They're secreting acid in the form of ammonia, NH4+, and that's dragging that chloride along with them. So their urine anion gap for chloride is going to be very negative. And if they have an RTA or even early renal failure, They can't secrete that hydrogen. They can't secrete that NH4+. They don't pee out their chloride, so they're going to have a positive urine anti-gap. So that's how the urine anti-gap works. All right, last question. And this other RTA one. The patient with multiple myeloma presents with a non-antigen metabolic acidosis and hypokalemia. He's on Sideboard D and daratumumab. The urine anti-gap is positive, indicating renal bicarb loss. Urine pH is 4.8. UA is glucosuria. No, his serum glucose is negative.
Type 2 renal tubular.
There we go. All right. So proximal RT. I honestly like when you said the first one. I wasn't sure because I almost like slipped around. No, they're good. They got it. Oh, okay. So they're okay. Proximal RTAs. So this is something affecting the proximal tubule. It's only going to be partial. If you had a full proximal tubular RTA, you would die like immediately because you would lose like so much bicarb that you just wouldn't be able to keep up. So this has to be like a partial defects in your proximal RTA. So what does your proximal tubule does? It reabsorbs bicarb, reabsorbs potassium, reabsorbs phosphate, it reabsorbs amino acids, and it reabsorbs most of your glucose. So one thing that can kind of clue you in that someone has a proximal RTA, and also they're not on an SGL2 inhibitor, is that they have a UA with glucosuria, so a little bit of glucose in their urine, but their serum glucose is 110. That means that they are basically losing glucose from a proximal RTA, and they're peeing that glucose out. So proximal RTA, there's a couple different causes. Drugs, acetazolamide is the big one you'll probably get tested on. Deposition, so biggest one is multiple myeloma, but also like weird metals, like someone who has like copper deposition from Wilson's may get it. And then like a vitamin D deficiency too, which is super random, but happens. Treatment is going to be bicarb, and you have to give a lot of bicarb, even more than distal, even more than the type 1. All right, so that was that. I think we got final JEP. So okay, so this one's going to be, you got to bet. So bet what you got, and then the final Jeopardy is going to be GI medical trivia. Sorry, we're a little over. Everything. Zero? All right. What do y'all want?
Team 4. Everything? All of it? What about team 3?
Everything? All right. All right, so you'll have to write this down, okay? All right. This steroid responsive disease is commonly misdiagnosed as primary sclerosing cholangitis. So you guys got to write it down. And I'll give you all a minute. Yeah, no, obviously, yeah, no cheating. What do you guys do for fun? So, okay, sorry. So you got a presentation of an MRCP with beating. So MRCP with beating of the biliary, the common biliary duct. And what's like on your differential for that? Okay, sorry, I should have explained that better. No, yeah. So you get a person with a like MRCP that shows beating of that common bile duct, but it's not PSC.
Yeah, it's steroid response.
And it's steroid responsive disease, so you should probably figure out that's, you know, that could be what it is. All right, I'm a. Is it you guys any writing it down yet? And then you guys are out. Sorry. All right, only one team got it, and it's team correct. So this is like the new sexy diagnosis, the IgG4 disease. So it can cause beating of your common bile duct, commonly misdiagnosed as PSC, and you really want to know if it's IgG4 disease or not, because it's steroid responsive and it's treatable. So very important to make the diagnosis. They actually now recommend anyone with a diagnosis of PSC should get a serum IgG4 to screen for IgG4 disease. Then you need a biopsy if it's positive. All right, so who won? Team 3.